Good afternoon, everyone. My name is Nathaniel Tan, and I'm a urology trainee at St George's Hospital, London. Today, I'll be presenting the outcomes of intravesical Botulinum Toxin treatment for post-prostatectomy patients with Detrusor overactivity. Long-term post-prostatectomy urinary incontinence affects between 3 to 10% of all patients who have undergone a radical prostatectomy for prostate carcinoma. This can have a severe impact on a patient's quality of life. The aim of the study was to evaluate the efficacy of intravesical Botox for patients with post-prostatectomy incontinence from overactive bladder. A retrospective review of all patients at a tertiary London hospital was conducted from January 2018 to December 2020. The type of urinary incontinence was confirmed on urodynamics. This was either stress urinary incontinence, Detrusor overactivity abbreviated as DO, or mixed urinary incontinence abbreviated as MUI. Demographics and symptom severity were collected. The procedures itself were day case procedures performed under local anesthetic, with one case performed under sedation due to patient's request. Patients were given oral antibiotics as prophylaxis prior to the procedure. A flexible cystoscope was used to perform an initial tracheostoscopy of the bladder. 100 units of Botox was mixed with 10 ml of 0.9% sodium chloride and administered in 10 injections evenly around the bladder, sparing the trigone and the ureteric orifices. Patients were then discharged on the same day. ICIQ OAB questionnaires were filled in by the patients before and 3 months after their procedure. 24-hour pad usage was quantified before and after the procedure as well. PG2 scores were filled in 3 months after the procedure to assess patient satisfaction with the intervention. Pad t-tests were used to assess for significance. With the results, 24 patients with OAB symptoms were identified to have had intravesical Botox in this time. The mean age of each patient was 70.3 years. 41.6% of the patients had pure Detrusor overactivity, and this was 10 of the patients in the cohort, while one patient, translating to 4.2%, had pure stress urinary incontinence with overactive bladder symptoms, and the remainder, 13 patients, which was 54.2% of our cohort, had mixed urinary incontinence. The mean total 24-hour pad use was 3.08 per day pre-operatively and 2.5 per day post-operatively at 3 months. 11 patients went on to have further treatment with Botox, 9 of which were from the DO group. 3 patients needed to temporarily self-catheterize after the treatment. Significant clinical improvement was found in the group with Detrusor overactivity when compared with the MUI group using pad t-tests, with p-value equals 0.001. Delving further into the results, we compare the DO cohort versus the MUI cohort. Patients with DO were more satisfied with their treatment as compared to patients with MUI, which was reflected in the PG2 scores. DO patients had a PG2 score of 2.3, while MUI patients had a PG2 score of 3.5. DO patients also experienced a 45% decrease in their pad usage post-operatively, from 2.9 pads pre-operatively to 1.6 pads post-operatively. MUI patients did not experience a significant decrease in their pad usage. Patients in the DO cohort had significant reductions in their OAB symptoms from 10.1 pre-operatively to 5.7 post-operatively. This was a statistically significant 41% improvement. Patients in the MUI cohort did not have a statistically significant reduction in their symptoms. Patients in the DO cohort also had a significant 26% reduction in their OAB bother scores from 26.9 to 19.9 post-op. There is higher patient satisfaction and more effective symptom control from Botox reported by patients with pure DO as compared to patients with mixed urinary incontinence. In conclusion, this is the largest reported series to date of the efficacy of intravesical Botox in this patient cohort. Significant improvements in patient satisfaction, quality of life, severity of incontinence symptoms, and pad use were noted for patients with pure Detrusor overactivity treated with Botox. they were also more likely to opt for repeat treatment rounds. There is no significant effectiveness in patients with mixed urinary incontinence. A larger cohort of patients is required for greater evaluation. For mixed urinary incontinence in males, initial treatment of the stress urinary incontinence component could be considered before the DO component. Thank you very much.